Welcome to Public Health America, a weekly program produced by BronxNet in partnership with Mercy College. I'm your host, Dr. William Latimer. Here on Public Health America, we speak with experts from an array of specialties across the liberal arts and health professions to provide you with not only the best science, but practical tips to live a healthier life. We also celebrate what studies have long documented, namely the unparalleled value of a liberal arts college education by setting the stage to pursue a career of your choice, increase lifetime earnings, and engage in civil debate. Our experts will share decisions they made and support they received that helped them to beat the odds. By sharing one or two life lessons, their stories may provide you with the inspiration and method to realize your dreams. This is Public Health America. Welcome to Public Health America. I'm your host, Dr. William Latimer. It is my pleasure to welcome Dr. Joseph Joe Braun, Associate Professor of Epidemiology at Braun University. Joe, welcome to the program.
Great to be here. Thank you so much for inviting me.
My pleasure. So I know you're doing some cutting edge work in a very difficult word to pronounce, perfluoroalkyl substances, or PFAS, on pregnant women, infants, and children. Please tell us what those substances are and a little bit about your work.
Sure. So perfluoroalkyl substances, which is a mouthful, or PFAS, which is what we colloquially call them. They're a broad class of anthropogenic chemicals. So that means they're made by humans, and they're made they're used in a lot of different products. There's thousands of them used in hundreds, if not thousands, of different everyday products or industrial processes. And these substances are characterized by having carbon-fluorine bonds, where they which are very strong, and gives these chemicals really desirable properties for stain repellency, water repellency, lubrication, and thus they're used in a lot of different things, from textile, like stain repellent textiles, firefighting foams, dental floss, and even things like guitar strings. And so they found their way into the environment in lots of different places. And because these chemicals have such a strong bond, they're environmentally, biologically, and chemically stable. So they don't break down very easily once they're released into the environment. And so they've ended up everywhere. We've detected them up above the Arctic Circle, in animals up there, as well as in water samples all over the world. And we detect them in the blood of nearly every human being on Earth. Mm-hmm. And we're concerned about these chemicals because they could have a wide range of health effects on us. And they hang around in our body for a really long time. Some of these chemicals can hang around in our body for 2 to 3 years, or even in some cases 5 to 7 years. And because of this, their persistent nature, we've dubbed them the forever chemicals.
That's fascinating and disturbing. When did these? Is it a fair question to ask? Since they're human-made, when did they come into being? When did they start to be produced?
Yeah, so we know that in the 1950s production began then. The 3M 3M company was one of the first makers of one of these chemicals. Another company, DuPont, has also made these chemicals as well, and they're used in a lot of different industries. But they've been used since the 1950s. And in recent years, the use of some of them has been phased out voluntarily by these companies, but they're replacing them with other perfluoroalkyl substances that are different in structure, but we know far less about their toxicity and potential health effects. And so we've dubbed this the chemical whack-a-mole game, where we do studies to show that one of them is bad or a couple of them are bad, and then they replace them with something else that we know nothing about.
Right. So, all right, let's talk about what's bad. Let's start with this. Are there PFAS chemical substances out there now that are known to be harmful? And if not, what are those that have been out there that have been discontinued, and obviously if you're studying the effect of the chemicals in pregnant women, infants and children, I have to believe that you're studying those populations because those chemicals can have a negative impact on those three, very important populations. So what are the negative impacts that we're aware of?
Yeah, so there's a couple of them that we have pretty good evidence that they're associated with negative health outcomes. One of them in particular, PFOA or perfluorooctanoic acid, and PFOS or perfluorosulfonic acid. These are chemicals that were used since the 1950s. Several of the companies that use them here in the United States have phased them out of use in recent years. But they're still detected in our blood because these chemicals hang around for almost forever. And they've been associated with a wide range of health outcomes. And so in pregnant women, there's some evidence they may be associated with hypertensive disorders during pregnancy, like preeclampsia or gestational hypertension. There's also evidence they're associated with low birth weight in babies that are born to women with higher levels of these chemicals. And then throughout childhood, there's really pretty strong evidence that exposure to these chemicals, either during pregnancy or in early childhood, is associated with reduced response to vaccines, specifically tetanus vaccines, MMR, and diphtheria. And these children have some decreased immune response after they get their vaccinations when they have higher levels of these chemicals in their blood. And what's really interesting is there's been some studies now coming out in relationship to COVID, in relationship to some of these chemicals, and suggesting that possibly severity of COVID symptoms is worse with people who have higher levels of these exposures. And so there's a lot of research interested in looking at these chemicals in relationship to COVID and COVID-related outcomes.
Sure. So you mentioned at the beginning that it sounds to me like a lot of these chemical substances are used to make our life easier, right? I mean, in other words, like you said like 7 things, none of which I can remember, but like things like water repellent, right? Mm-hmm. So dental floss. I mean, I've got my dentist telling me to floss 6 times a day, and I want to make my dentist happy. What should I be staying away from?
So right now, this is a challenging thing, and we're doing some work in this area right now to figure this out. One of for most people, diet is the major source of exposure, and that's because these chemicals end up in our drinking water and in landfills or out on biosolids or fertilizer that's applied to crops, and so we ingest them. We don't know which foods are the worst to eat. And so, the best advice I give to people is to try to just eat a balanced diet. In some populations, drinking water is the next biggest exposure, or it could be the largest source of exposure. So, using a tap water filter is a really good idea. And there's the NSF, which is a rating organization for tap water filters, has a database of filters that can filter out perfluoroalkyl substances. And so that's a easy way to reduce your exposure to PFAS as well as other chemicals. But otherwise it becomes challenging because these things are used as I noted, in lots of different things. And I think this is where I think is the real need for us to have better regulation of chemicals in our society, because it's hard for individuals to, even like myself, who are informed, to reduce exposure to so many of these things all at once. Whether it's the dental floss, the stain repellent clothing, the textiles I'm using. And so finding ways to, it's challenging. And so we need regulations that protect people. One of the things we're investigating right now is whether or not we can do simple interventions in young children's homes to reduce their exposure, because we know young kids get lots of exposure from mouthing things that have been on the floor or putting their hands in their mouth, and also from breathing these chemicals, because these chemicals can go into the air. They're semi-volatile. And so we're doing things looking at air filtration as well as residential dust control, which is just a fancy word for cleaning up really well and reducing the amount of dust in the home, to see whether or not we can improve or reduce children's exposure using simple interventions that we could hopefully scale up on to implement on a larger scale.
So what's the one question I have is, can we test our tap water for PFAS? Is that something that's easy to do, or is it too difficult and just go out and get the water filter?
People can do that, and the EPA has released health advisory limits for drinking water levels. They actually recently revised them where they're very, very low, and they're so low, in fact, that probably almost all the public drinking water supplies in the country have levels above this health advisory limit now. One thing people can do is they can go onto their local, if they're on using public drinking water, they can go onto their local drinking water company or services website and see if they've been testing for PFAS and to see what the levels are. There are laboratories out there that do that, but it's probably cost prohibitive to most people to do. These analyses to quantify levels of PFAS in water are probably a few $100s per sample. So I don't think that's something realistic for families to do. And by that point, you might as well just buy the filter.
Right. Sure, makes sense. Makes sense. So what's the order of magnitude? Here's the thing. I have a bias that is right or wrong, that, all of these human-made chemicals probably have all kinds of baggage that go with them, despite the fact that, I can now walk around with a stain-free shirt. What is the real order of magnitude? I mean, in population studies, you can have an odds ratio of 1.2, and it's significant, but it might not represent a real risk to the masses. I don't know if I'm asking this question clearly, but this sounds very alarming. It's like, I have 3 kids. I want to go home now and I want to throw out all my dental floss. I want to get a filter. I want to do, protect. I want to figure out, goodness knows, all their clothes probably have 80,000 chemicals that I'm not aware of. What's the actual risk to the no pun intended, the average Joe on the street?
So I think for most of us, the risk is probably low. And then there was recently a panel convened by the National Academies of Science, Engineering, and Medicine that has put forth clinical guidelines to screen people for PFAS exposure. And they're actually putting forth guidelines to state that in individuals who don't have suspected PFAS exposure, either from drinking water or occupational exposures, that there's probably no reason to do monitoring of their levels of PFAS in their blood. However, for people who might have levels or might have exposure to these chemicals, either occupationally or through drinking water, they do recommend screening for levels of these PFAS, and they provide levels, 3 tiers of levels of whether additional screening is necessary for some of the PFAS related diseases or not. And so they have developed guidance now that hopefully will be implemented into clinical practice, or could be implemented into clinical practice. Absent that, individuals could go and test their blood levels to see, at the individual level, whether this is, worth doing something. So I do think that there is a rationale to do this clinically because of the extent of exposure. I mean, this is a highly prevalent exposure affecting millions of people. So even if these odds ratios are small, it's, this could still have a pretty tremendous impact at the population level.
Sure. No, that makes sense. We're going to take a quick break. When we come back, Dr. Joe Braun is going to tell us a little bit about his life, his undergraduate experience, and how going to college set the table for him to do this excellent research and have a great career. This is Public Health America. I'm your host, Dr. William Latimer. We'll be right back. Welcome back to Public Health America. I'm your host, Dr. William Latimer. So, Joe, in this segment, I always open with the exact same question. Where were you born, and what were some of your formative experiences?
So I was born in Janesville, Wisconsin, which is a town in the Midwest, in southern Wisconsin. I went to high school at a above average public high school. I always had a love of science growing up, especially in high school. I had some really great, a couple of really great chemistry teachers that really inspired me to be interested in biology and chemistry. But I was never quite sure what I wanted to do with all of that. And I went to college at the University of Wisconsin-Madison and did a 4-year degree there in biochemistry. Not really sure that what I was going to do with that degree when I got done with it. But still being very interested in science. And I left college sort of disheartened in that degree, disheartened because I was working in a laboratory, often working with, rats and mice and doing experiments on them and grinding their organs up and, measuring proteins in them. And I found it very far removed from health, which I became increasingly interested in. I was actually out at a friend's house one night, and this person there told me that she had her master's in public health and that she was doing studies to try to get pregnant women to quit smoking during pregnancy. And I thought, wow, that sounds really interesting. That sounds very pragmatic and like something I would want to do. And that got me really interested in shifting, towards more clinical focus. And so I actually went back and got another degree, another undergraduate degree in nursing. And it was when I was there in nursing school that I was mentored by Dr. Laura Anderko, who was an associate dean there and professor. And she just let me, she gave me some ideas to start working with publicly available epidemiologic data to do studies. And so I started working with this and teaching myself epidemiology and biostatistics. And I became really passionate about this. And it was through that experience that I just got very excited about epidemiology and public health. And that's really what translated into, publishing my first paper and going on to want to get my doctoral degree.
That's great. Pre-pandemic, I remember when I joined the Department of Mental Hygiene at Johns Hopkins University, my older sister jokingly said, I wasn't aware you were a dentist. Meaning that pre-pandemic, nobody knew what epidemiology was. But now, post-pandemic, epidemiology is like a common term. And you came up through the ranks, at a time where finding public health was a journey unto itself. And that's what you're kind of defining. And hopefully these days, more people attending college understand that epidemiology is an actual discipline and that it has practical implications to promoting health, which is your point or part of your point. Where did you do your nursing degree?
University of Wisconsin-Milwaukee.
Okay. Great. Well, another nice thing about your story is that, you got what most people would argue is a great degree from one of the best universities in the world, Madison, Wisconsin. But then you went back and you got another degree when you realized that there was more that you wanted to do. Did you go on for a public health degree after that?
Yeah. So afterwards, I did do my master's in I did my master's in science and public health and epidemiology at UNC, a PhD there. And it was, again, what was really critical for me there, and I think, is that I mentorship through, by reaching out to people doing research in this field of children's mental health, which I had a lot of interest in. And I had really great mentors. Dr. Bruce Lanphier was one of my mentors. And then, as I into doing a postdoc at Harvard, I worked with Robert Wright and Russ Hauser. And it's really having these great mentors is what really has solidified my interest in doing this and knowing that I'm well supported. I do agree with you, though, that one of the things about epidemiology that's really interesting is I think it offers a really sort of pragmatic set of skills, and public health in general, sort of viewing the world through this lens of health and thinking about things pragmatically. And I think there's a lot of career choices for people out there with it that aren't necessarily, going and working in a research institution or in a school of public or in a health department, because it's just you can view a lot of problems through this lens of public health or epidemiology in a very practical way.
So let's go back to undergrad, though. You get your biochem degree from University of Madison, University of Wisconsin-Madison, and then there's a period of time before you decide to go back to get a nursing degree. What was going on that led to that decision?
There's a great story there. So, when I was at UW-Madison, I was competing as a triathlete on the triathlon team, swimming, biking, and running. And I thought that I wanted to try and go as far as I could doing that competitively after college and see if I could, how far I could go. And so I took a year off where I was working part-time in a laboratory and then also training and competing. And it was during that time I discovered I wasn't cut out to be an elite level athlete. I still love to run and bike and swim, but not at that level. But what happened was that I was forced to reckon with the fact that I wasn't good enough to be an elite level athlete, despite the fact that I loved doing it. And so I had to stop and take time to figure out what is it that I love to do that I'm also good at. And so that's what really led me down that journey of discovering, I enjoyed, nursing and that practice of taking care of people and helping others, as well as really that I enjoyed the quantitative aspects of epidemiology, as well as the pragmatic aspects of public health. And I discovered that I was good at it too. And so it was really, that failure is what set me up for success. And I don't think maybe failure is too strong of a word, but that moment of knowing that I wasn't good enough for that one thing gave me the opportunity to find the thing that I really enjoyed doing that I was good at.
Sure. And I've mentored a great many students, and I'm sure you have too. I think one of the most difficult thing to do with a traditional age student that's talented is to prepare them for the inevitable, which is failure, and that's a part of life, and you bounce back from it and do the next thing. And that could be a paper that's not accepted. It could be not getting an A in every class. It could be other challenges as well, and that's not even counting other very real challenges that many students face in Philadelphia, in New York City, like feeding their family, access to healthy food, staying away from PFAS chemicals. So if you were to give some advice to our listeners of what college meant to you in either of its iterations, what would that be?
I think one of the most important things is to find good mentorship. And that doesn't have to be a formal relationship. It could just be, it can be something informal, but I think finding someone who's, can give you good advice, and be there to look out for you and advocate for you. I think that's really important. That could be an instructor. It could be, someone who runs a lab who you work in, but finding someone like that to work with you and to be there to offer you advice and to be a sounding board for you as well is great. And even at my stage of my career, I'm in my 40s now, I still have mentors, that I rely on and talk to, frequently. So I think that's one of the number one things. The second thing is college is a time for you to try new things. I mean, you've got a lot of freedom in terms of the options in front of you. So try new things. See what you may not get an A in it. You may not be good at it, but you might discover though that you are good at it, or that you really like it, or both. So it's a chance to do that. There's not, it gets harder to do that the further along you go in life, I think. So college is really a great chance to do that.
Sure. So clearly, at least two really important points: the importance of mentors. And I say it to students all the time: introduce yourself to your faculty, to your teachers, let them know who you are. They're going to be the people that are in your corner for decades to come. Mm-hmm. Certainly, I have an undergrad mentor that literally now I've known for nearly 40 years. That's how old I am. And we're still good friends. And I know if I called on him for assistance, he would be there to help. Were there any, with about a minute left, were there any additional challenges you faced that you sort of had to work your way through in order to have the success you've had in college and beyond?
I think the biggest challenge that you face, that I think you alluded to, is just that, it's a series of ups and downs a lot, and it's not always going to be great. And I think it's knowing that, the lows can be low and the highs can be high, and it's great when you're on the high and things are going great, but things can go poorly too. And, things will get better. And I think it's just important to calibrate your expectations to that. And if you do that, I think you can be a lot happier. And I find that works well for me, is in academia, and a lot of jobs are like that, where there's a lot of up and down over and over and over again. And being ready for that just makes it easier to deal with the lows.
Makes a lot of sense. I want to thank Dr. Joseph Braun, and I want to thank our viewers for tuning in to Public Health America. I'm your host, Dr. William Latimer. See you next time. Until then, take care.